Today, we are going to discuss about cor pulmonale under the following headings. To start with, the definition of cor pulmonale is dilation and hypertrophy of right ventricle in response to diseases of pulmonary parenchyma or vasculature which results in pulmonary artery hypertension. Hence, this is also called as pulmonary heart disease. So it is also called as pulmonary heart disease. Alright, now what causes cor pulmonale? Any diseases that affect your pulmonary parenchyma like COPD, interstitial lung diseases, cystic fibrosis or bronchiectasis can cause cor pulmonale. Any diseases that affect pulmonary vasculature like your thromboembolic diseases, both acute and chronic, and also pulmonary artery hypertension can cause cor pulmonale. When you're exposed to chronic hypoxia or when there is hypoventilation, again it can result in cor pulmonale. Conditions like while you're living at high altitudes for a longer time, or when the person is going to have chest wall dysfunction, or when there is going to be neuromuscular disorders, then all these conditions are going to cause chronic hypoventilation or it is going to cause hypoxia. In addition to all this, whenever the person has got morbid obesity and also when the person has got polycythemia, they can also be more prone to develop cor pulmonale. So now we will discuss about the pathophysiology behind the disease. Now all the causes which leads to cor pulmonale actually forms this pulmonary artery hypertension, which is causing your right ventricle to fail to contract. Now any diseases which affects your pulmonary parenchyma or your vasculature is going to cause pulmonary artery hypertension. So how? Now this is going to cause smooth muscle proliferation of your vessels. So there is going to be smooth muscle proliferation of your vessels, and there is also infiltration of your inflammatory cells. So the inflammatory cells are also infiltrated. So now all these together will cause occlusion of your pulmonary artery, which increases resistance and which causes pulmonary artery hypertension. And sometimes it can also trigger the thrombotic events. So it can also trigger the thrombotic events, which can also cause pulmonary artery hypertension. Now, whenever a person is exposed to chronic hypoxia, two things can happen. The first one is proliferation of your vascular smooth muscles. So you know this is ultimately going to cause pulmonary hypertension. The other is going to be reduction in the levels of nitric oxide. Nitric oxide basically is a vasodilator. So when the levels are going to reduce, obviously it can cause vasoconstriction. Second, when the levels of endothelin 1 is going to increase. So this causes vasoconstriction. And third, when there is increase in level of your platelet derived growth factor. So what does this platelet derived growth factor do? So it causes proliferation of your smooth muscles and also your fibroblast. So therefore, all these together can cause pulmonary artery hypertension. Now what happens when there is pulmonary artery hypertension? Normally your right ventricle is going to be very thin and compliant. So this is your right side and this is your left side. So normally your right ventricle is going to be very thin and compliant. And you know right ventricle opens into pulmonary artery. So this pulmonary artery resistance is almost 1/10 of your entire systemic vascular resistance. So therefore your right ventricle is pumping into a low vascular resistance vessel. So when this pulmonary artery is going to have increase in pressure and there is going to be pulmonary artery hypertension, the afterload is going to increase. And you know whenever there is increase in afterload, the cardiac output is going to reduce. So therefore there is going to be reduction in cardiac output. Now whenever the cardiac output reduces, there can be compensatory mechanisms which gets activated, like activation of sympathetic nervous system, and because of renal hyperperfusion, There can be activation of renin-angiotensin-aldosterone system. There can be secretion of antidiuretic hormone. So what happens when there is activation of sympathetic nervous system? It temporarily increases your cardiac output by increasing myocardial contractility. Now, because of your activation of renin-angiotensin-aldosterone system or because of ADH, there is going to be salt and water retention. Now, when there is salt and water retention, as compensation, there is also release of ANP and BNP, your atrial natriuretic peptide and brain natriuretic peptide, so that this causes some amount of natriuresis. Now, this in the long term can result in decompensation. This in long term can cause decompensation and cardiac output can very much be affected because of the damage to your myocytes. So initially in your compensatory stages, there can be dilation and hypertrophy of your right ventricles, which will be more deranged when it becomes decompensated. Now, the ventricles normally in the right side can handle the volume better than pressure. So this can handle increase in volume to a better extent than the pressure overload. So when the pressure is going to increase in your pulmonary artery, it is going to increase in your right ventricle, which is going to again affect your right atrium, which is again going to affect your superior vena cava and inferior vena cava. Now, whenever it is reflected in superior vena cava, it is reflected in your JVP as increase in the JVP. Whenever it is going to be reflected in inferior vena cava, you know liver drains to hepatic vein, receiving blood from GIT and spleen through portal vein. So whenever there is increase in pressure in IVC, it is also reflected in your hepatic vein, in your liver, in portal vein, in GIT, in spleen, and also in your systemic vessels. So whenever it is going to be in liver, it causes hepatomegaly, it causes ascites. In bowel, it causes bowel edema. In spleen, it causes splenomegaly. And in the other places, it is going to cause edema. So this is how it is going to progress with. Now you have acute and chronic cor pulmonale. So what causes acute cor pulmonale? Whenever there is a sudden and severe stimulus, you have a sudden and a severe stimulus. Like say for example, you have a massive embolus. So these people will have right ventricular dilation, but there will not be hypertrophy. So they will have right ventricular dilation without hypertrophy. But whenever there is going to be a slowly evolving stimulus, then this results in right ventricular hypertrophy. Subsequently, there will be dilation also. So whenever a person has got chronic cor pulmonale, it can be decompensated when triggered by hypoxia, which causes pulmonary vasoconstriction, or when there are exacerbations of COPD, or when there is an acute pulmonary emboli, or when the person has got sepsis. All this can trigger this chronic cor pulmonale to become very much decompensated. What are the clinical features the person can present with? The first one is dyspnea. So why the person can have dyspnea? It can be because of inefficient ventilation. So whenever the ventilation is going to be inefficient, then it can cause dyspnea. Or whenever the diseases of the lungs are going to be fibrosing. So the fibrosing lung diseases is going to increase the work of breathing. So therefore, this can also cause dyspnea. And whenever there is altered respiratory mechanics, say for example, you're going to have COPD, then obviously the respiratory mechanics is going to be altered, which can cause dyspnea. The second one, so these people with cor pulmonale, they cannot tolerate any amount of exertion because the cardiac output demand which has to increase is not met when the person is going to have cor pulmonale. So therefore, they can have exertional syncope because of reduction in the cardiac output. As I told you, when this increase in the pressure is going to affect all your organs, then this can cause abdominal pain ascites, swelling of legs. It can cause orthopnea and PND when your right ventricular failure is so severe that it compromises so much of your cardiac output, so much of your left ventricular output. Then the person can have orthopnea and paroxysmal nocturnal dyspnea. So that completes the symptoms. Now moving on to the signs, you can see edema in dependent parts. Cyanosis. Cyanosis can be because of reduction in cardiac output, or it can be because of your systemic vasoconstriction, or it can be because of the ventilation perfusion mismatch. Tricuspid regurgitation will be present, so you can hear the hollow systolic murmur, and this murmur will increase with inspiration, which is called as Carvalho sign. In severe RV dysfunction, this Carvalho sign might be absent also. And then you can feel for the right ventricular heave, which is the parasternal heave, close to the left border of the sternum. And with abdominal examination, you can have hepatomegaly and ascites. And finally, moving on to investigations. ECG will show features like P pulmonale, which can be suggestive of your pulmonary artery hypertension, or right axis deviation, or features of right ventricular hypertrophy. Chest X-ray can show you cardiomegaly, or it can also show you the enlargement of your pulmonary artery. So it can show the enlargement of your pulmonary artery. Spirometry will help you to find whether there is an obstructive lung disease or there is a restrictive lung disease. Now moving on to ABG, your arterial blood gas analysis will show you whether there is hypoxia or hypercapnia. The next one, CT angiography, it is important because it can show you any acute thromboembolic events present or not. HRCT helps you to find the interstitial lung diseases better. Echo. So echo, if you want to check the status of your right ventricle, whether the thickness, the chamber, everything is fine, that can be done with echo. To check for the status of your pulmonary and your tricuspid valves, that also requires echo. Now right heart catheterization, this is important because this can tell you the mean arterial pressure perfectly. So if you want to estimate the mean arterial pressure, this can be better estimated with your right heart catheterization. And whenever this pressure is going to be more than 25 millimeters of mercury, then it is suggestive of pulmonary artery hypertension. MRI will tell you whenever there is going to be a severe lung disease. To assess the status of right ventricle, you require MRI. And second, your BNP and NT-proBNP levels, yes, it gets elevated in your right or your left ventricular failure. Ventilation perfusion scanning, so this will tell you if there is any chronic thromboembolic pulmonary hypertension. So that can be found using ventilation perfusion scanning. Treatment basically involves treating the underlying disease. So whenever there is an underlying pulmonary disease, so that has to be treated. And second, with NIV, non-invasive ventilation and bronchodilators, it is going to help with the symptom of the person. So this is going to reduce the work of breathing so that the person improves with dyspnea. Adequate oxygen. Phlebotomy is preferred when the person has got polycythemia. So phlebotomy can be done if the person has got polycythemia. Diuretics can decrease the salt and the water accumulated. Anticoagulants, because when the person has got thromboembolic events, yes, the person have to be put on anticoagulants. Now treating the pulmonary artery hypertension is the mainstay of treatment. So how do you treat? By giving calcium channel blockers and by giving phosphodiesterase 5 inhibitors. Now normally your phosphodiesterase 5 causes your hydrolysis of cyclic GMP. And you know your nitric oxide acts through cyclic GMP. So whenever your cyclic GMP is going to reduce, your nitric oxide is going to reduce. It cannot exert its action. So therefore there cannot be vasodilation because nitric oxide normally causes vasodilation. So when you're going to give some inhibitors of phosphodiesterase, then this is going to reduce. When this is going to reduce, then this nitric oxide is going to increase. So when this increases, there is going to be some amount of vasodilation. So therefore this can help in reducing the pressure in your pulmonary arteries. So that completes the discussion on cor pulmonale.